Welcome to the Dr. Izzy's Medical Podcast channel.
Multiple myeloma. Multiple myeloma, also known as plasma cell myeloma and simply myeloma, is a cancer of plasma cells, a type of white blood cell that normally produces antibodies. Often, no symptoms are noticed initially. As it progresses, bone pain, anemia, kidney dysfunction, and infections may occur. Complications may include amyloidosis. The cause of multiple myeloma is unknown. Risk factors include obesity, radiation exposure, family history, and certain chemicals. Multiple myeloma may develop from monoclonal gammopathy of undetermined significance that progresses to smoldering myeloma. The abnormal plasma cells produce abnormal antibodies, which can cause kidney problems and overly thick blood. The plasma cells can also form a mass in the bone marrow or soft tissue. When one tumor is present, it is called a plasmacytoma. More than one is called multiple myeloma. Multiple myeloma is diagnosed based on blood or urine tests finding abnormal antibodies, bone marrow biopsy finding cancerous plasma cells, and medical imaging finding bone lesions. Another common finding is high blood calcium levels. Multiple myeloma is considered treatable, but generally incurable. Remissions may be brought about with steroids, chemotherapy, targeted therapy, and stem cell transplant. Bisphosphonates and radiation therapy are sometimes used to reduce pain from bone lesions. Rarely, Epstein-Barr virus, EBV, is associated with multiple myeloma, particularly in individuals who have an immunodeficiency due to, for example, HIV/AIDS, organ transplantation, or a chronic inflammatory condition such as rheumatoid arthritis. Signs and symptoms. Because many organs can be affected by myeloma, the symptoms and signs vary greatly. Fatigue and bone pain are the most common symptoms at presentation. The CRAB criteria encompass the most common signs of multiple myeloma. Calcium, serum calcium greater than 1 mg per deciliter higher than the upper limit of normal or greater than 11 mg per deciliter. Renal insufficiency, creatinine clearance less than 40 ml per minute or serum creatinine greater than 2 mg per deciliter. Anemia, hemoglobin value of greater than 2 grams per deciliter below the lowest limit of normal, or a hemoglobin value less than 10 grams per deciliter. Bone lesions, osteolytic lesions on skeletal radiography, CT, or PET and CT. Bone pain. Bone pain affects almost 70% of people with multiple myeloma and is one of the most common symptoms. Myeloma bone pain usually involves the spine and ribs, and worsens with activity. Persistent, localized pain may indicate a pathological bone fracture. Involvement of the vertebrae may lead to spinal cord compression or kyphosis. Myeloma bone disease is due to the overexpression of receptor activator for nuclear factor kappa B ligand, RONKL, by bone marrow stroma. RONKL activates osteoclasts, which resorb bone. The resultant bone lesions are lytic in nature, and are best seen in plain radiographs, which may show punched-out resorptive lesions, including the raindrop appearance of the skull on radiography. The breakdown of bone also leads to the release of calcium ions into the blood, leading to hypercalcemia and its associated symptoms. Anemia. The anemia found in myeloma is usually normocytic and normochromic. It results from the replacement of normal bone marrow by infiltrating tumor cells and inhibition of normal red blood cell production, that is hematopoiesis, by cytokines. Impaired kidney function. Impaired kidney function may develop, either acutely or chronically, and with any degree of severity. The most common cause of kidney failure in multiple myeloma is due to proteins secreted by the malignant cells. Myeloma cells produce monoclonal proteins of varying types, most commonly immunoglobulins and free light chains, resulting in abnormally high levels of these proteins in the blood. Depending on the size of these proteins, they may be excreted through the kidneys. Kidneys can be damaged by the effects of proteins or light chains. Increased bone resorption leads to hypercalcemia and causes nephrocalcinosis, thereby contributing to kidney failure. Amyloidosis is a distant third in the causation. People with amyloidosis have high levels of amyloid protein that can be excreted through the kidneys and cause damage to the kidneys and other organs. Light chains produce myriad effects that can manifest as the Fanconi syndrome, type 2 kidney tubular acidosis. Infection. The most common infections are pneumonias and pyelonephritis. Common pneumonia pathogens include S. pneumoniae, S. aureus, and K. pneumoniae, while common pathogens causing pyelonephritis include E. coli and other gram-negative organisms. The greatest risk period for the occurrence of infection is in the initial few months after the start of chemotherapy. The increased risk of infection is due to immune deficiency. Although the total immunoglobulin level is typically elevated in multiple myeloma, the majority of the antibodies are ineffective monoclonal antibodies from the clonal plasma cell. A selected group of people with documented hypogammaglobulinemia may benefit from replacement immunoglobulin therapy to reduce the risk of infection. Neurological symptoms. Some symptoms may be due to anemia or hypercalcemia. Headache, visual changes, and retinopathy may be the result of hyperviscosity of the blood depending on the properties of the paraprotein. Finally, radicular pain, loss of bowel or bladder or carpal tunnel syndrome, and other neuropathies may occur. It may give rise to paraplegia in late presenting cases. When the disease is well controlled, neurological symptoms may result from current treatments, some of which may cause peripheral neuropathy, manifesting itself as numbness or pain in the hands, feet, and lower legs. Symptoms in mouth. The initial symptoms may involve pain, numbness, swelling, expansion of the jaw, tooth mobility, and radiolucency. Multiple myeloma in the mouth can mimic common teeth problems like periapical abscess or periodontal abscess, gingivitis, periodontitis, or other gingival enlargement or masses. Diagnosis. The globulin level may be normal in established disease. A doctor may request protein electrophoresis of the blood and urine, which might show the presence of a paraprotein band, with or without reduction of the other immunoglobulins. One type of paraprotein is the Bensay-Jones protein, which is a urinary paraprotein composed of free light chains. Quantitative measurements of the paraprotein are necessary to establish a diagnosis and to monitor the disease. The paraprotein is an abnormal immunoglobulin produced by the tumor clone. Additional findings may include a raised calcium level, raised serum creatinine level due to reduced kidney function, which is mainly due to casts of paraprotein deposition in the kidney, although the cast may also contain complete immunoglobulins, Tom Horsfall protein and albumin.
Other useful laboratory tests include quantitative measurement of IgA, IgG, and IgM to look for immune paresis, and beta-2 microglobulin, which provides prognostic information.
On peripheral blood smear, the Rouleau's formation of red blood cells is commonly seen, though this is not specific. Histopathology. A bone marrow biopsy is usually performed to estimate the percentage of bone marrow occupied by plasma cells. This percentage is used in the diagnostic criteria for myeloma. Immunohistochemistry, staining particular cell types using antibodies against surface proteins, can detect plasma cells that express immunoglobulin in the cytoplasm and occasionally on the cell surface. Myeloma cells are often CD56, CD38, CD138, and CD319 positive and CD19, CD20, and CD45 negative. Flow cytometry is often used to establish the clonal nature of the plasma cells, which will generally express only kappa or lambda light chain. Cytogenetics may also be performed in myeloma for prognostic purposes, including a myeloma-specific fluorescent in situ hybridization and virtual karyotype. The plasma cells seen in multiple myeloma have several possible morphologies. First, they could have the appearance of a normal plasma cell, a large cell 2 or 3 times the size of a peripheral lymphocyte. Because they are actively producing antibodies, the Golgi apparatus typically produces a light-colored area adjacent to the nucleus, called a paranuclear halo. Medical imaging. The diagnostic examination of a person with suspected multiple myeloma typically includes a skeletal survey. This is a series of X-rays of the skull, axial skeleton, and proximal long bones. Myeloma activity sometimes appears as lytic lesions, with local disappearance of normal bone due to resorption. And on the skull X-ray is punched-out lesions, also called raindrop skull. Lesions may also be sclerotic, which is seen as radiodense. Overall, the radiodensity of myeloma is between -30 and 120 Hounsfield units. Magnetic resonance imaging is more sensitive than simple X-rays in the detection of lytic lesions, and may supersede a skeletal survey, especially when vertebral disease is suspected. Occasionally, a CT scan is performed to measure the size of soft tissue plasmacytomas. Bone scans are typically not of any additional value in the workup of people with myeloma. Staging. In multiple myeloma, staging helps with prognostication but does not guide treatment decisions. The Duryea-Salmon staging system was used historically and was replaced by the International Staging System, published by the International Myeloma Working Group in 2005. The revised International Staging System was published in 2015 and incorporates cytogenetics and lactate dehydrogenase. Stage 1. Beta-2 microglobulin less than 3.5 mg per liter, albumin greater than or equal to 3.5 grams per deciliter, normal cytogenetics, no elevated LDH. Stage 2, not classified under Stage 1 or Stage 3. Stage 3, beta 2m greater than or equal to 5.5 mg per liter, and either elevated LDH or high-risk cytogenetics T4,14, T14,16, or del17p. Treatment. Treatment is indicated in myeloma with symptoms. If there are no symptoms, but a paraprotein typical of myeloma and diagnostic bone marrow is present without end organ damage, treatment is usually deferred or restricted to clinical trials. Treatment for multiple myeloma is focused on decreasing the clonal plasma cell population and consequently decrease the symptoms of disease. Chemotherapy. Initial treatment of multiple myeloma depends on the person's age and other illnesses present. The preferred treatment for those under the age of 65 is high-dose chemotherapy, commonly with bortezomib-based regimens, and lenalidomide dexamethasone, to be followed by a stem cell transplant. A 2016 study concluded that stem cell transplant is the preferred treatment of multiple myeloma. There are two types of stem cell transplants to treat multiple myeloma. In autologous hematopoietic stem cell transplantation, the patient's own stem cells are collected from the patient's own blood. The patient is given high-dose chemotherapy, and the patient's stem cells are then transplanted back into the patient. The process is not curative, but does prolong overall survival and complete remission. In allogeneic stem cell transplantation, a healthy donor's stem cells are transplanted into the affected person. Allogenic stem cell transplantation has the potential for a cure, but is used in a very small percentage of people. Furthermore, a 5 to 10% treatment-associated mortality rate is associated with allogeneic stem cell transplant. People over age 65 and people with significant concurrent illnesses often cannot tolerate stem cell transplantation. For these people, the standard of care has been chemotherapy with melphalan and prednisone. Recent studies among this population suggest improved outcomes with new chemotherapy regimens, for example, with bortezomib. Treatment with bortezomib, melphalan, and prednisone had an estimated overall survival of 83% at 30 months, lenalidomide plus low-dose dexamethasone and 82% survival at 2 years, and melphalan, prednisone, and lenalidomide had a 90% survival at 2 years. There is support for continuous therapies with multiple drug combinations of anti-myeloma drugs bortezomib, lenalidomide and thalidomide as initial treatment for transplant-ineligible multiple myeloma. Further clinical studies are required to determine the potential harms of these drugs and the effect on the person's quality of life. A 2009 review noted, deep venous thrombosis and pulmonary embolism are the major side effects of thalidomide and lenalidomide. Lenalidomide causes more myelosuppression, and thalidomide causes more sedation. Chemotherapy-induced peripheral neuropathy and thrombocytopenia are major side effects of bortezomib. Treatment of related hyperviscosity syndrome may be required to prevent neurologic symptoms or kidney failure. Maintenance. Most people, including those treated with autologous hematopoietic stem cell transplantation, relapse after initial treatment. Maintenance therapy using a prolonged course of low-toxicity medications is often used to prevent relapse. A 2017 meta-analysis showed that post-autologous hematopoietic stem cell transplantation maintenance therapy with lenalidomide improved progression-free survival and overall survival in people at standard risk. A 2012 clinical trial showed that people with intermediate and high-risk disease benefit from a bortezomib-based maintenance regimen. Relapse. Reasons for relapse include disease evolution, either from the selective pressure applied by treatment or by de novo mutations, and/or if disease was inadequately represented in the initial biopsy. Relapse within the first 18 months of diagnosis is considered as functional high-risk multiple myeloma. Depending on the person's condition, the prior treatment modalities used, and the duration of remission, options for relapse disease include retreatment with the original agent, use of other agents, and a second autologous hematopoietic stem cell transplantation. Later in the course of the disease, it becomes refractory to formerly effective treatment. This stage is referred to as relapsed refractory multiple myeloma. Treatment modalities that are commonly used to treat relapsed refractory multiple myeloma include dexamethasone, proteasome inhibitors, for example bortezomib and carfilzomib, immunomodulatory IMiD drugs, for example thalidomide, lenalidomide, and pomalidomide, and certain monoclonal antibodies. Survival expectancy has risen in recent years, and new treatments are under development. Kidney failure in multiple myeloma can be acute or chronic. Acute kidney failure typically resolves when the calcium and paraprotein levels are brought under control. Treatment of chronic kidney failure is dependent on the type of kidney failure and may involve dialysis. Several newer options are approved for the management of advanced disease. Belantamab mafodotin, a monoclonal antibody against B-cell maturation antigen, BCMA, also known as CD269, indicated for the treatment of adults with relapsed or refractory multiple myeloma who have received at least 4 prior therapies, including an anti-CD38 monoclonal antibody, a proteasome inhibitor, and an immunomodulatory agent. Carfilzomib, a proteasome inhibitor that is indicated as a single agent in people who have received 1 or more lines of therapy. In combination with dexamethasone or with lenalidomide and dexamethasone in people who have received 1 to 3 lines of therapy. Daratumumab, a monoclonal antibody against CD38 indicated in people who have received at least 3 prior lines of therapy, including a proteasome inhibitor and an immunomodulatory agent, or who are double refractory to a proteasome inhibitor and an immunomodulatory agent. Elotuzumab, an immunostimulatory humanized monoclonal antibody against SLAMP7, also known as CD319, indicated in combination with lenalidomide and dexamethasone in people who have received 1 to 3 prior therapies. Isatuximab, a monoclonal antibody against CD38 indicated in combination with pomalidomide and dexamethasone for the treatment of adults with multiple myeloma who have received at least 2 prior therapies, including lenalidomide and a proteasome inhibitor. Ixazomib, an orally available proteasome inhibitor indicated in combination with lenalidomide and dexamethasone in people who have received at least 1 prior therapy. Panobinostat, an orally available histone deacetylase inhibitor used in combination with bortezomib and dexamethasone in people who have received at least 2 prior chemotherapy regimens, including bortezomib and an immunomodulatory agent. Selinexor, an orally available selective inhibitor of nuclear export indicated in combination with dexamethasone in people who have received at least 4 prior therapies and whose disease does not respond to at least 2 proteasome inhibitors, 2 immunomodulatory agents and an anti-CD38 monoclonal antibody. Idecabtagene vicleucel, first cell-based gene therapy, was approved by FDA in 2021 for the treatment of adults with relapsed or refractory multiple myeloma who have received at least 4 prior therapies. Stem cell transplant. Stem cell transplant can be used to treat multiple myeloma. Stem cell transplants come with a risk of a graft versus host disease. Mesenchymal stromal cells may reduce the all-cause mortality if they are used for a therapeutic reason, and the therapeutic use of mesenchymal stromal cells may increase the complete response of acute and chronic graft versus host disease, but the evidence is very uncertain. The evidence suggests that mesenchymal stromal cells for prophylactic reason result in little to no difference in the all-cause mortality, in the relapse of malignant diseases, and in the incidence of acute graft versus host disease. The evidence suggests that mesenchymal stromal cells for prophylactic reason reduce the incidence of chronic graft versus host disease. Other measures. In addition to direct treatment of the plasma cell proliferation, bisphosphonates, for example, pamidronate or zoledronic acid, are routinely administered to prevent fractures. They have also been observed to have a direct antitumor effect even in people without known skeletal disease. If needed, red blood cell transfusions or erythropoietin can be used for management of anemia. Side effects. Chemotherapies and stem cell transplants can cause unwanted bleedings and may require platelet transfusions. It was seen that platelet transfusions for people undergoing a chemotherapy or a stem cell transplantation for the prevention of bleeding events had different effects on the number of participants with a bleeding event, the number of days on which a bleeding occurred, the mortality secondary to bleeding, and the number of platelet transfusions depending on the way they were used. Supportive treatment. Adding physical exercises to the standard treatment for adult patients with hematological malignancies like multiple myeloma may result in little to no difference in the mortality, in the quality of life, and in the physical functioning. These exercises may result in a slight reduction in depression. Furthermore, aerobic physical exercises probably reduce fatigue. The evidence is very uncertain about the effect and serious adverse events. Palliative care. Multiple national cancer treatment guidelines recommend early palliative care for people with advanced multiple myeloma at the time of diagnosis and for anyone who has significant symptoms. Palliative care is appropriate at any stage of multiple myeloma and can be provided alongside curative treatment. In addition to addressing symptoms of cancer, palliative care helps manage unwanted side effects, such as pain and nausea related to treatments. Teeth. Oral prophylaxis, hygiene instruction, and elimination of sources of infection within the mouth before beginning cancer treatment can reduce the risk of infectious complications. Before starting bisphosphonates therapy, the person's dental health should be evaluated to assess the risk factors to prevent the development of medication-related osteonecrosis of the jaw. If there are any symptoms or radiographic appearance of medication-related osteonecrosis of the jaws like jaw pain, loose tooth, mucosal swelling, early referral to an oral surgeon is recommended. Dental extraction should be avoided during the active period of treatment and treat the tooth with non-surgical root canal treatment instead.
Thank you for listening Dr. Izzy's Medical Podcast Series. If you want to support this project, please subscribe the channel and like this video. Thank you.